Hello and welcome to Talking General Practice, the podcast from GP Online. I'm Emma Bower, the editor of GP Online. Today on the podcast, I'm joined by our deputy editor, Nick Bostock, to talk about some of the key news stories affecting general practice. Coming up today, we're talking about two major government announcements and what they could mean for general practice in the coming months. Firstly, just before Christmas, the government announced an £889 million funding uplift for the GP contract in 2025-26. We'll be looking at whether that funding is enough to stabilise practices and what the government will be asking for in the next contract. Meanwhile, this week has seen the government and NHS England unveil the elective reform plan, which sets out steps to hit the 18-week referral to treatment target by the end of this Parliament. The plan includes a number of measures involving GPs and primary care, and we'll be discussing what it means for general practice. In our good news story this week, we highlight those GPs recognised in the New Year's Honours List. So first up, let's talk about the GP contract for 2025-26. Just before we all down tools for Christmas, the government announced it would increase overall funding for general practice in England by £889 million from April this year, which it said would be the biggest boost to GP funding since the 5-year contract was introduced in 2019. Nick, what do we know about this new funding? It is new money, isn't it?
For starters, as you said, Emma, the total amount the government has said it will increase GP funding by in the coming financial year is £889 million. The government has said that uplift means a 7.2% cash increase in funding, and it's estimated that will translate into a 4.8% real terms increase. When the government announced it on the 20th of December, it was actually a bit of a surprise because only a couple of days beforehand, the Health and Social Care Secretary, Wes Streeting, gave the impression in an evidence session with the Health and Social Care Select Committee that GPs might have to wait until early 2025 for any information on funding for the year ahead. But in the end, he said he decided to make the announcement early to provide reassurance about what he called the government's strong commitment to support general practice. And on the point about whether it's new money rather than rebadged from other budgets in some way, all we know about that really is from what the BMA said when the funding was announced just before Christmas. The BMA said at that stage that it had been given assurances that, yes, it would be new money for general practice, and it said that its plan was to hold the government to account on that. Wes Streeting said, like you said, the funding package was the largest uplift to GP funding since the start of the 5-year GP contract framework. That's the one that started in 2019 and ended in 2024. And he said it means the government will be reversing the recent trend with a rising share of total NHS resources going to general practice. So that suggests that in percentage terms, this funding uplift for general practice is going to outstrip the uplift for other NHS services in the year ahead. And that idea of a rising share of the total NHS budget going to general practice is something that the profession's leaders have been calling for at least a decade. And the BMA GP committee sort of cautiously suggested that maybe conversations with government and messages from the profession about the crisis in general practice and the need to support GPs are starting to pay off. Ultimately, though, we're still at a very early stage, and it won't be until contract negotiations between the BMA, the government and NHS England run their course over the next couple of months that GPs will know exactly what it's going to mean for them. And the BMA has said it's hopeful that this could provide a lifeline for practices, but there are some major caveats which we'll come on to.
We spent quite a lot of time on the podcast at the end of last year talking about the increase in employers' national insurance contributions and the rise in the national minimum wage, both of which due to come into effect from April, and how they were likely to push many practices to the brink if the government didn't provide some sort of support and cover the costs involved. Is this increase that we're talking about here, is it enough to stabilise practices, do you think?
So this is obviously one of the major caveats that I mentioned just now. And as we've discussed on the podcast before, the rise in employer national insurance contributions that's going to kick in from April this year has huge cost implications for general practice. The BMA said that along with an increase in the minimum wage that takes effect at the same time, the average practice could face increased costs of more than £30,000 a year. And some LMCs have put the figure at substantially more than that. I mean, in fact, obviously, depending on the size of practices, some practices' bill is going to be much, much bigger again. But across England, these costs are going to come to at least £200 million over the next year, and potentially a fair bit more. So unless there's a separate settlement to cover that cost increase, a big chunk of the £889 million headline figure is going to be stripped back out of general practice and head back to the Treasury almost immediately. The BMA says it's committed to reaching a consensus on managing those extra costs for practices. So exactly how those fit into this funding package or fit with the funding package is going to be a really big part of the contract negotiations through the start of the year, you'd think. In terms of whether the overall uplift is enough to stabilise practices, clearly a substantial injection of additional funding is welcome. It's going to benefit practices. But there are a couple of other points to consider about the sort of wider context that are important. And one major factor is going to be the pay increase practices are asked to pass on to staff. So until practices know exactly what percentage rise they're expected to award to salaried GPs and other staff they employ, is it 2%, is it 4%, is it 6%? Determining whether £889 million is enough or more than enough or nothing like enough is basically impossible. So that's a really big factor. We also know that whatever proportion of this funding goes into practices' core funding through the current funding formula will have a widely variable impact from practice to practice because there's so much variation in things like staff costs. And another point is that even after the overall funding uplift for general practice in the current financial year, which came in the form of a 7.4% uplift to practice's global sum funding, the BMA said that even after that, GP funding was still around £350 million below the level it was at in 2018-19 in real terms. So practices are still playing catch-up compared with the position they were in 5 or 6 years ago. So this uplift obviously needs to be seen in that context as well.
It is really important, isn't it, to remember that we've talked a lot about the rise in employers' national insurance contribution and the impact that's going to have. Many practices were really, really struggling before they found out about those extra costs they were going to have to bear in April. So it's not just that extra cost that we have to cover with this money. It's also the years of underfunding that have preceded it, which many practices were already in a precarious state before they even found out about these extra costs. Do we know how the money is going to be distributed? Because that is obviously going to be a key thing about it, which will determine actually how much practices get in their pocket, is how they actually share this £889 million out.
We don't have detail at this stage on how the funding is going to be shared between practices or how it'll be spread across different funding streams that general practice relies on. And I guess that's the kind of stuff that's going to have to be thrashed out in contract negotiations. But one thing that the BMA has said is that the funding is split across the core GP contract. So that means the basic funding practices receive through the contract funding formula, and the PCN DES, the Directed Enhanced Service, which governs practices' involvement in primary care networks and things like the Additional Roles Reimbursement Scheme, the ARRS. So how much will go to each, we don't know yet. But one point Wes Streeting made when he announced the funding package was that part of his intention was to reassure existing GPs in jobs created through the ARRS that their roles would continue to be funded through the coming financial year. And just to recap, the government said soon after taking office in the summer that it would create 1,000 GP jobs through the ARRS, and it made £82 million available to fund those roles for the second half of the current financial year, so from October 2024 to March 2025. We think the number of GPs who've actually taken up ARRS jobs so far is way below the 1,000 target at the moment. But if 82 million was for 1,000 jobs for 6 months, presumably double that would be needed for all of the 25-26 financial year. So again, there's another thing that's a really big chunk potentially of this £889 million. The government's also said it'll bring practice nurses into the ARRS for the first time from April. So how much is that going to cost? Will that come from existing ARRS funding? Or is that also a further draw on the new funding, the £889 million? Another factor we don't yet know is how much of this new money will go on things like new targets. And if there are new targets, how much work they'll involve and how effectively that might be balanced out by changes to existing targets for general practice. So basically, there are a lot of questions. And what's clear is that a substantial chunk of the money in this £889 million package may already be spoken for, whether it's to cover national insurance costs, ARRS GP jobs or nurses' jobs, next year's pay rise for staff employed in practices, and so on. And that means that ultimately there may not be a lot left for GP practices to do what they really need to do to stabilise themselves, which is to recruit and retain more GPs.
Yeah, you've touched on some of this there, but obviously this funding is all going to be linked to the GP contract for 2025-26. And the Health and Social Care Secretary, Wes Streeting, in the announcement was really clear that the money would be used to drive reforms and improve patient care. As you mentioned, Nick, final details of what's going to be in the contract are still being thrashed out between the government, NHS England and the BMA. And we're not expecting to see final details on that till the spring. But the government has already hinted at some of the changes that will be coming from April. So what I guess it's probably worth looking at what we already know about what the government wants general practice to do. So firstly, as you mentioned there, Nick, the additional roles reimbursement scheme, that's not going anywhere, despite the fact that many GPs would like to see all of that money reinvested into core funding. The ARRS looks like it's here to stay for the time being. You mentioned GP jobs there, and the government said that hundreds more newly qualified GPs will be recruited through the ARRS in the coming year, which suggests we might even see an expansion of that element of the scheme rather than just a rolling over of the current situation. The early announcement was intended, as you said, to reassure GPs who have already taken on those jobs, but also perhaps to encourage some more GPs to actually throw their hat into the ring for those jobs, because the government has made a big deal about this and it will want to see this being viewed as a success in the coming months. So I think they'll be really keen to make sure more GPs are applying for those jobs. You mentioned practice nurses as well, being added to the ARRS. That's a big change. Some GPs are quite concerned about that and have warned, adding nurses to the ARRS could potentially undermine practices because, their point is if the government wants to grow the number of practice nurses, it should be investing more money into core general practice because that's where practice nurses can be of most use rather than at a network level. You also mentioned targets, Nick. The government has already said the QOF is going to be scaled back from April. The Quality and Outcomes Framework, the number of indicators is going to be cut from 76 to 44, which the government says will help free up GPs' time and cut bureaucracy. But it isn't clear which indicators are going to be scrapped. In April last year, so April 2024, 32 of the 76 indicators were suspended and income protected. So it could well be those same indicators are the ones that get scrapped completely. That would get you to 44. So if that's the case, then it isn't really going to cut any work from practices because they haven't been doing it this year anyway. 19 of those indicators are the disease registers, which practices will have to still do anyway. 6 were the quality improvement indicators, which basically just haven't existed this year. But like I say, we don't know for sure which indicators are going to go. The government also said there will be new financial incentives for practices that go above and beyond to prevent the most common killers like heart disease. That was the quote there. And the announcement about the funding suggested that will probably be focused on identifying and treating patients with high blood pressure. But again, not really any detail on what that means or how much money will be earmarked for that. I think perhaps the most controversial thing in that announcement is the government said it wants practices to ensure patients can contact the surgery electronically throughout core hours, as well as on the phone, which it says means that more people will be able to book an appointment or speak to a doctor. Again, not really clear exactly what that means, but it could well be a new contractual requirement for practices to keep open online consultation systems throughout the day. And I think GPs will be quite wary of that because at the minute practices can turn these off if they get too many requests and feel they can't cope with the number of requests coming in. So I think there'll be a lot of concern if they lose the freedom to do that. Something that wasn't mentioned in there was no mentions of incentives for continuity of care, despite the fact that Wes Streeting said shortly after the general election that the government planned to introduce those. But what the government did say is that all of the reforms taken together would ensure that those patients who would benefit most from continuity would be more likely to get it. presumably because the government thinks the changes it's making will free up GP time. So as you say, clearly quite a lot that we're going to have to wait and find out about before we get a sense over whether or not this is a good deal for the profession. Nick, Wes Streeting has called on practices, basically made this announcement about funding, and then he's called on practices to stop collective action. Is that likely, do you think? What's the BMA said about that?
It's obviously not the first time he's called on practices to stop collective action, but I'm not sure he's going to have much more joy this time than the last time he called for it. Personally, I don't think there's any chance practices will step back from collective action at this stage. As we've been discussing, there's still so much detail they simply don't have about how this funding package is going to affect them. So until that picture's really clear, I can't see practices deciding to step back or stop collective action. Another factor here is that only a couple of months ago, LMCs actually voted for a ballot on more significant industrial action and for a special conference to talk about that and the national insurance issue. So on that basis, we're still quite a long way off the government and general practice sort of burying the hatchet. Another reason I can't see practices stepping back from collective action is that ultimately none of the actions they've been taking so far are anything that breaches their contract. Measures like limiting contacts with patients to safe levels or stopping unfunded work are all things that the BMA has been suggesting practices should do for years to try and take control of their workload. And we know that for many GPs, things like adopting safe working advice has been absolutely transformative to, how bearable their daily workload is. So the idea of reversing that, I think, is pretty unimaginable for most GPs.
It seems really clear that the contract negotiations that are going on now are going to be absolutely crucial to all of this. It'll be interesting to see what happens with the BMA. You mentioned that special conference there that we talked about at the end of last year, when that's likely to happen, if it will happen, because obviously what is going on in negotiations will have such an impact on what happens from April that I don't know, it's quite hard to see whether the BMA would actually hold that conference until they know the upshot of all of this, really.
I think that's absolutely right, that it seems quite likely that any ballot on significant industrial action or, like you say, a conference is unlikely to happen until the BMA knows exactly where it stands. Because if the BMA feels like it's, moving closer towards a good settlement with the government or something it's happy with, something that it thinks it can present to the profession and that GPs are going to be at least relatively happy with, you'd be surprised if they decided to escalate industrial action anyway before they know where they stand on all that kind of stuff.
Yeah. Obviously, lots to keep an eye out for in the coming weeks and months. This week, the government and NHS England unveiled their plan to reform elective care and cut the massive NHS waiting list. And while this may initially sound like it all focused on hospitals, there's quite a bit in the plan that will affect general practice. So, Nick, in the broadest terms, what exactly is this plan trying to do?
So the central aim of this plan the government's published is to tackle long waits for NHS hospital treatment, the so-called NHS backlog. The government's promised that by the end of the current Parliament, it'll bring waiting times down to 18 weeks. And that's the target in the NHS Constitution, but it's one that currently is being routinely missed.
So how bad is the waiting list at the moment, and what are the short and long-term targets the government wants to get to?
So figures for October 2024 showed that there were more than 3 million cases that had been waiting more than 18 weeks, and nearly 250,000 been waiting for more than a year. So there's a really long way to go to meet the target the government's aiming for by the end of the current Parliament. In the shorter term, the government said that by the end of the next financial year, so by the end of March 2026, 65% of patients will be treated within 18 weeks. And as things stand, just under 59% of patients are being treated within that timescale.
And how much of a difference could this make to GPs if the government hits these targets? Because we know, like waiting lists, they do have a big impact on workload in general practice, don't they?
The shift by the end of the Parliament, if the government and the NHS can get there, could make a really substantial difference for general practice, both in terms of workload and one of the other major challenges, which is abuse and complaints from patients. There are currently about 6.3 million patients waiting for 7.5 million hospital procedures. So this is 1 in 10 of the population in England that we're talking about. We know that while patients face long waits for hospital care, they often come back repeatedly for GP appointments because they need help in various ways. They might need help managing pain or other symptoms, and they're also often coming back to practices, not necessarily for appointments, but sometimes just for queries to reception and other staff. And they're adding to pressure simply by asking, understandably, for updates on when they might be able to get the treatment their GP often referred them for a long, long time ago. We know from our own polling that GPs say around 1 in 3 consultations in general practice are for patients who are on the waiting list for hospital treatment. And 1 in 3 consultations means something like 120 million appointments a year. Clearly, not all of those would necessarily be avoided if patients weren't awaiting hospital care. But there's no doubt that if the waiting list could come down in terms of overall numbers and in terms of the delay for treatment, that would make a really big difference to general practice workload and quite likely to morale, because practices would feel more able to get patients the care they need when they need it, and they'd face fewer complaints and fewer encounters with angry patients.
There was a specific mention of GPs in the plan as well. The main thing in the plan was new payments for making use of advice and guidance. What do we know about that?
Yeah, so it's a central plank of the plan that practices will be offered a payment of £20 per request submitted through the advice and guidance system. So advice and guidance has been controversial because although in some parts of the country GPs are already actually paid to use it, in many areas they haven't been paid. And it's often been seen as a mechanism that instead of offering GPs access to advice from hospital consultants on how to manage certain cases, certain patients, it simply ends up transferring huge amounts of work from secondary care into general practice, because practices are asked to carry out tests and so on that normally would have been carried out as part of the hospital process. And simply, practices just don't have the time or funding to take that extra work on. The government says it wants to drive up the total number of requests through advice and guidance from 2.4 million last year to about 4 million a year. And it thinks that doing this could prevent something like 800,000 hospital referrals a year.
So I suppose the big question is £20 enough to cover that work? It doesn't sound like very much money.
Well, so clearly, if general practice is going to take on work on a scale that could stop 800,000 hospital referrals, it's a really significant amount of workload. The BMA said previously that advice and guidance should be something that general practice is paid millions of pounds a year for. And 4 million requests a year, if that's the target, at £20 a pop, means it would be worth £80 million a year. So in one sense, it looks like another sign of the BMA GP committee starting to get the government to provide some of the funding it's been asking for, something to respond to some of the asks that it's putting forward. But whether it's enough is a tougher question. As I said, some areas already receive funding through local deals for taking part in advice and guidance. And in one area we looked at last year, they were receiving something like £26 per advice and guidance request, and they'd actually asked for that amount to go up to just over £30. So by that benchmark, perhaps £20 isn't enough, although it's also possible that GPs in some areas could be able to negotiate local top-ups, for example.
The other thing in the plan that would probably have an impact on GPs is there was some mention of plans for GPs to refer patients direct for scans as well, without the need for them seeing a specialist. I mean, we know that GPs already do that for some things, and I guess the implication is that they're going to expand it to cover more specialties. What do we know about that?
Improving direct access to diagnostics is another really long-standing issue for general practice, something GPs have been pushing for a long time. NHS England has said that as part of the elective reform plan, it'll make it easier for GPs to book patients in for diagnostics. And in terms of the scale, NHS England said hundreds of thousands of patients would be able to be booked in for tests, checks and scans by their GP. It mentioned specifically patients with conditions such as breathlessness, asthma in children and young people, and postmenopausal bleeding as groups that could benefit from speeded up access. Plan also talks about more patients being offered follow-up consultations or treatment dates on the same day as a scan or a test. So it's also about faster access to booking these checks, but also about sort of making processes more efficient around those checks.
A big part of the plan is about this idea of expanding patient choice, and this is something that's kind of been talked about all the time for years and years and years. And I think the idea behind all of this is, so when a GP does refer a patient for a treatment or a scan, for example, the idea is that the patients will then be able to manage that referral themselves effectively and book in for their appointment at a time and a place that's most convenient for them. Running alongside this plan, the government has also announced it's struck a new deal on expanded use of the independent sector to help cut waiting lists, in particular for gynaecology, ENT and orthopaedics. So patients could potentially have the option of choosing a private provider once they've been referred. The plan says that currently only 8% of bookings after referrals are made using the Manage Your Referral website or the NHS app. And the government and NHS England really want to ramp up that figure. The idea is that if people can book their own appointments, they will be less likely to miss them. And according to the plan, around 8 million appointments were missed in 2023-24. So they really want to bring that figure down as well. Underpinning all of that is obviously this really expanded role for the NHS app, in particular linking hospitals into the app. That could actually help general practice as well, couldn't it?
Yeah, so as I touched on earlier, one major factor that adds to pressure on GP practices is angry patients asking for updates about when hospital appointments they've been waiting a long time for are going to happen, or asking for practices to chase the hospital to try and speed things up. So that's something often outside practices' control they get a lot of stick for, because the GP practice is the visible face of the health service, and patients can walk in or call fairly easily, whereas it can be a lot harder to get through to a hospital department to try and chase an appointment. Part of this plan, as you said, is for an overhaul of the NHS app so that more patients can use it to view and manage appointments, book tests and receive test results, and to make it easier to communicate directly with hospitals about all this, which could take some of that pressure off practices to act as the go-between between patients and the hospital. And as you said, the government says this could also mean a big reduction in missed hospital appointments, which can also be a factor that adds to GP practice workload, because although hospitals aren't always meant to, they often ask practices to re-refer when a patient misses an appointment in hospital.
There's some other aspects of the plan that are probably worth mentioning because they will have an impact on general practice. There's also going to be a big push on expanding community diagnostic centres. So there should be 170 of these up and running by March this year, and the government says it's going to expand some of these and build another 5. They are going to be expected to be open 12 hours a day, 7 days a week by March 2026 to help improve access to diagnostics. Hospitals and these community centres are also going to be expected to develop and deliver at least 10 straight-to-test pathways by March 2026 as well. So presumably these are the services that GPs will be able to refer patients straight into testing, and ICBs have been told that these 10 pathways should focus on the tests that patients are waiting the longest for in each local area. There's also going to be, inevitably in this plan, there's also a big focus on productivity and tech, making use of AI, for example, in community diagnostic centres and in surgical hubs. There's going to be a push on patient-initiated follow-ups as well. So this is where patients decide themselves whether they think they need a follow-up appointment. And apparently AI is going to help identify the patients for whom that will be most suitable. AI is also going to help identify which patients are most likely to miss appointments, apparently. And the plan says that that in itself could save 1 million missed appointments a year. So obviously lots of new tech coming on. Another thing about tech, there's going to be a big push on remote monitoring and wearable tech as well. And that could also have an impact on general practice as things progress as well, I would imagine. I mean, the plan says remote monitoring should be offered as standard across all long-term conditions where it's clinically appropriate, which it says will save 500,000 appointments a year from 2026-27 onwards. And I guess as the use of that sort of tech expands across the NHS, you could potentially see more and more of that ending up being used in general practice or being used by GPs to look at how patients are progressing with particularly those with long-term conditions. And finally, the other thing perhaps worth mentioning, the plans to change pathways for 5 specialties, which are ENT, gastroenterology, respiratory, urology and cardiology. From all of those, the initial signs of what they're trying to do is push for more procedures and more care to be provided in the community, so avoid people going into hospital in the first places. So those are areas where GPs will like to see more straight-to-test pathways, for example, more use of that remote monitoring and an expansion of testing in the community diagnostic centres, I expect. So, Nick, both of the things we've talked about on the podcast today, the contract uplift and the elective reform plan, the government has used both of them as an example to show they are serious about shifting the focus away from hospitals and providing more care in the community. But you wrote a story this week suggesting that the government is going to have to really ramp up capacity in general practice if it wants to see a real shift in focus, didn't you?
Yeah, so a big part of the plan to sort out the NHS waiting list hinges on the idea of moving care from hospitals into the community, and which is one of the three big shifts that the government said will underpin its plans to reform the health service. And we talked earlier about plans to increase use of advice and guidance, which, as things stand, many GPs have stopped doing as part of collective action. But even if some money is made available, ultimately capacity in general practice is limited because there are still fewer GPs now than there were a decade or so ago. Until those workforce issues are sorted out, any plan to move more care into general practice is going to be on shaky ground, especially at a time when we know that appointments are running at absolutely record levels. A survey we wrote about this week from the Medical and Dental Defence Union of Scotland, which is one of the big medico-legal organisations in the UK, showed that most GPs say they just don't have the staff to cope with these plans to shift more healthcare into the community as things stand. And so the backdrop these plans are set against is one in which many GPs say they're considering leaving general practice because of stress and burnout. So the prospect of more work is not one that many are going to welcome, and that's what this survey from the MDDUS showed. The big warning from the BMA on this was that ultimately, until the government sets out a concrete plan to fix the workforce, until we see how they're going to get more bums on seats in general practice, there can't really be too much confidence that the waiting times plan is going to work.
Before we go, we've just got time for our regular good news story, and this week it's about those GPs who were recognised in the New Year Honours List. Dr Matt Kearney, a GP and Senior Advisor on Cardiovascular Health at UCL Partners, an organisation that brings together researchers, the NHS and industry, was awarded an OBE for services to health and the prevention of cardiovascular disease. Dr Kearney was NHS England's first National Clinical Director for CVD between 2016 and 2019. RCGP Wales Chair and former guest of this podcast, Dr Rowena Christmas, was awarded an MBE for services to general practice. Dr Stephen Reaney, a GP from County Armagh in Northern Ireland, received an MBE for voluntary services to the Northern Ireland Ambulance Service. Dr Chris Robinson, a GP in Inverness Shire in Scotland, received an MBE for services to the community in Lochaber. Professor Claire Wilkinson, Emeritus Professor of General Practice at the North Wales Centre for Primary Care Research at Bangor University, received an MBE for services to primary care research, teaching and practice. Congratulations to all of those doctors. Well, that's it for this week. Thanks so much for listening, and thanks to Nick. I'll be back next week, so please do join me then. In the meantime, don't forget you can keep up to date with all the latest news affecting general practice and access a host of other resources on our website at GPonline.com.